We have often seen women during pregnancy coming to us with very severe pulmonary edema and very severe symptoms, and we have detected mitral stenosis in them. And we have safely performed balloon mitral valvotomy in many of these women. And there is ample evidence all over the world and from our own experience that balloon mitral valvotomy, particularly if performed during the second trimester of pregnancy, can be accomplished with great deal of safety and efficacy, and it's often life-saving in these individuals. And then we can actually do balloon mitral valvotomy with a fluoroscopic time of as less as 1 minute, and then the procedure is done in 20 to 30 minutes, and the woman is safe for the rest of her pregnancy. So therefore, when it's done with adequate shielding and in carefully selected patients whose anatomy, the valve anatomy, is suitable for balloon mitral valvotomy, it significantly reduces mortality and morbidity. But if you look at rheumatic heart disease, especially mitral stenosis, it adversely impacts both maternal and fetal health, and rates of intrauterine growth retardation and prematurity are increased significantly in women who have complicated rheumatic heart disease. And in women with severe mitral stenosis, the mortality can go up to 10 to 20%, whereas in asymptomatic moderate mitral stenosis, most of the times pregnancy can continue with less than 1% morbidity and mortality. So how do we do a pre-pregnancy planning in these women? We have to define the severity of the mitral stenosis, and mitral stenosis is severe. So prior to planned pregnancy, these women should have, if suitable, a balloon mitral valvotomy. If not suitable, they should go for a surgical mitral commissurotomy. The question is, the dilemma is, if the woman requires a valve replacement, what do we do? So then it becomes a very difficult clinical problem, because a young woman often has to go for a metallic valve, and metallic valve means lifelong Coumadin, and then that means it becomes very difficult to plan pregnancy. So a woman who conceives while on Coumadin, there's a significant risk of fetal anomalies, because Coumadin is a teratogenic drug. So quite often, when we see women who have valvular heart disease and who may need a valvular replacement, we try to manage them medically as much as possible, and we urge them to complete their go through their pregnancy, and once childbirth happens, then we send the woman to definitive surgical correction. But in case it's something like a mitral stenosis, we can always do a balloon mitral valvotomy, and then we can solve the problem. Similarly, women who have severe aortic stenosis, we can do a palliative balloon aortic valvotomy, and that will help them tide over the period of pregnancy, and we can plan definitive surgical correction after that. Okay, finally I'll tell you about peripartum cardiomyopathy, which is a common problem. In fact, this peripartum cardiomyopathy is something it's a cardiomyopathy that is diagnosed within the last month of pregnancy and within 5 months postpartum. And it is a diagnosis of exclusion, because we need to exclude any determinable cause of heart failure. It is because of some kind of an immune-mediated mechanism, and their diagnostic criteria is to find an ejection fraction of less than 45%. Typically occurs in multiparous women of 20 to 35 years of age and present with features of heart failure. And if a woman has had peripartum cardiomyopathy during the past pregnancy, she is urged against any future pregnancies, because there is a high risk of recurrence of heart failure during every subsequent pregnancy, putting the mother at a significant risk of morbidity and mortality. And especially if they have residual left ventricular dysfunction. And of course, if diagnosed during pregnancy, the management is similar to management of any heart failure, diuretics, and we don't give ACE inhibitors until postpartum. We can give beta blockers, digoxin, and anticoagulation as is required. Even in this situation, vaginal delivery is preferred, and you want to give anesthesia, epidural anesthesia is preferred. I'm sorry for the slides being jumbled up. I think there's something lost in transmission. And finally, congenital heart disease. Most congenital heart defects like ASD, VSD, which are hemodynamically not very significant, are well tolerated during pregnancy, as are regurgitant lesions. The only conditions which will affect the pregnant woman as well as the fetus adversely are cyanotic heart disease, which are untreated, whether it's Fowler's tetralogy or Eisenmenger syndrome. And with that, I conclude my presentation, and if there are any doubts, I'm happy to answer.